Hello, everyone. Today is November 6th, 2021. I'm here with Scott Fassas. Scott is a internal medicine resident. Thanks for coming on the podcast, Scott.
Glad to be here, Krush. Big fan since day one.
Thank you. Since day one. Yes. What was that? Okay.
No idea.
I've been a big fan of you since day one, too. Those days
Really?
in the fraternity,
Same gamma class.
Gamma class with Glenn,
And six other people.
six other people, Gabriel Alshiak.
Yep.
Wow, that was nearly 10 years ago now. That was 9.5 years ago.
Yeah, it's pretty wild, actually. I think about that, how long ago undergrad was and the first and second year of it.
Yes. Yeah, that was a long time ago. Different. Did you know you wanted to be a doctor then and go to medical school?
That was a plan. That was a plan out of high school. It was kind of just something I guess had some good experiences with doctors and like my own pediatrician, and then during undergrad I just continued to kind of build on those, and so it's kind of always there, but I feel like it got reinforced during just experiences while as an undergrad.
Nice. What good experiences did you have with doctors growing up?
Yeah, so I really enjoyed my pediatrician a lot. I always felt like he was someone who just like was so relaxed, so calm, somebody that I could always talk to. I was never scared to go to the doctor or anything like that. I actually wanted to be a pediatrician originally when I first pursued medicine, and then that just kind of changed over time. But I've always been interested in just, you know, the human aspect of medicine, kind of being able to engage with people on like a very intimate level.
Internal medicine, that's a huge part of it, isn't it? Engaging with people.
Yeah, exactly. I mean, it's one of like the biggest catch-all kind of specialties you have, and there's so many different routes that you can take, or you can keep it very broad and just kind of work with all different types of diseases and conditions and people of various backgrounds.
Do you have any routes that you're eyeing? Because you're right now in year one, correct?
hmm
And how long is your program?
So my program is 3 years.
Oh, that's
So
pretty
that
short.
Yeah, it's pretty short, which is one of the nice things about internal medicine residency. And depending on if I want to pursue any other specialties, those sometimes are like another 3 years. I'm still kind of up in the air at this point. It's kind of a balancing act between how much time it's going to take and how much I would enjoy it. And right now, I'm just kind of exploring different like electives and different specialties to see what I might enjoy.
Okay. So really you're going to gain a better idea in the coming months to years.
Yeah, and I've already done a few. So I've like looked at cardiology and gastroenterology, and I'm gonna be hopefully looking at maybe pulmonology and critical care. And I know I'm not that interested in gastroenterology. The other ones, I'm still kind of figuring it out as I go along.
What's gastroenterology?
You work basically doing like colonoscopies and things like that, and so you deal with a lot of poop. And
Wow.
yeah, it just wasn't really my cup of tea.
No, that doesn't sound very fun.
No, not
What's
not for me.
what did you say the other one was? Plumen
Pulmonology.
Plumenology? What's that?
It's pulmonology. Um,
Pulmonology?
yeah, like the pulmonary system, so like your lungs.
Got
So
it.
basically, they focus kind of on the pulmonary system, and lots of times people who do that will actually do critical care as well. And so they'll also be like working part time in the ICU. And so you'll do like what are called bronchoscopies, which is what they take a scope and they go down into your lungs. Sometimes they'll like wash fluid down there, take samples. They can do like procedures down there. And then the critical care, like working in the ICU, is basically, that's where a lot of the COVID patients are ending up. So that's just people who are very high intensity level of care. Um, and so those are some of the aspects that I'm looking at right now. But I'm taking this year to figure it out and figure out, what would be best for me and just long term, what would make me happiest.
Okay. Well, that's good that you're taking that time. It's could go, don't want to make the wrong decision and do something you don't like for 30 years.
Yeah, exactly. And I think that's one of the things that, I really do love medicine a lot and I enjoy doing it. And so for me, I'm glad that, I'm doing something that I like. And, gastroenterology, for instance, a lot of people love it and you make a lot of money, but I didn't enjoy it. I didn't enjoy kind of, every time someone comes into the hospital, they have a GI bleed, you're doing a rectal exam to see if they have blood. And for me, that's just not very interesting to do that. I feel like you're doing a lot of the same sort of procedures over and over. And so, nothing against those doctors. We need those doctors and they do great work, but it's just not interesting. And I would much rather take, something that pays less, um, just to know that I'm happy what I'm doing every day I go to work.
Nice. That's important. And wow. What program were you in last year?
So last year I was doing a research fellowship, and that was with otolaryngology.
What's otolaryngology?
That's like ear, nose, throat surgery, basically. So anything that you can think of that could happen to the ear, nose, or throat. A lot of the times they'll kind of deal with those. So people who lose their hearing, people who lose their voice, people who have like sinus conditions, people who have head and neck cancer, things like that.
Okay. Did you do any clinical work last year?
Not in the same sense that I'm doing now. It was I did clinical research, and so I dealt with patients a lot, but I wasn't really taking care of them in the same regard that like a resident does in the same capacity where you're diagnosing, you're managing their conditions. We were more so just if patients came in and they're eligible for studies or clinical trials, then we would enroll them or ask them if they would like to participate in the trial, kind of discuss the risks and benefits, see, if that was something in line with their goals. And if it was, then we'd enroll them in the clinical trial and kind of follow them over time. And so it's a very interesting side of like academia that I never really had any involvement with until last year. And so it's kind of cool to see that aspect and see how things get done from like a clinical research standpoint.
That is cool. Wow. So you gain your subjects in real time and you need their permission in order to access their data or whatever samples they're willing to give you or you need.
Yeah, exactly. So they would essentially, depending on what study we're doing, because we did a lot of studies, there's a whole bunch of different types of research. Some is like retrospective, and so usually you have to go through what's called an IRB process, and you need to get approval through this IRB process to access patients' records. And
Internal
so that's like retrospective. So imagine all these things happen to patients, and then in like from 2002 to 2010, and then 2011, you wanted to see does smoking increase the risk of head and neck cancer. And then so you kind of go back in the data and look at how many patients smoked, how many ended up with head and neck cancer, how many didn't smoke, how many of those, something like that. So that would be retrospective. A lot of what we did was also prospective. And so, you come up with a hypothesis at the very beginning of a study and say, and it could be the same hypothesis saying, I think that smoking increases the risk of head and neck cancer. But this time now you enroll people in the study and you say, you ask them, are you a smoker? Are you not a smoker? And then moving forward, you'll follow them over time. And so it's just a little bit of a stronger research study and research type because, uh, especially if you're doing it randomized, I mean, that maybe wasn't the best example for a randomized one, but if you're doing something randomized, then it's controlling for a lot of the other variables that can be affecting research studies, like confounding factors and things like that. And so lots of times we would do randomized studies for like pain management after surgery and see, if we do the standard regimen versus this altered pain, multimodal pain management regimen, which patients have the lowest pain scores after surgery or which patients use the least amount of opiates after surgery. And so something like that is a lot stronger than a retrospective study where you just look back and things are not always documented correctly and then charts. There's a lot of user error when you're trying to go back through and find things, whereas if you do it prospectively, you can hopefully be like, okay, we're collecting this data, this data, this data, and this data, and every day you collect like that specific data, so you know what you're looking for beforehand. So it's like a lot usually better study design.
Got it. Because the question that you're looking for, and it's not just like, oh, this happened to stumble upon,
Yeah.
and you know, this you might correlate, cause it. We didn't actually test for this. This is just
Hmm.
something we found. So it's a lot less conclusive that that's actually causation.
Hmm.
If Is that correct?
Yeah, basically, they always say correlation is not causation, and so, but essentially, that's kind of the thought process behind, a prospective trial is that you can design, every variable. You can exclude people going into the study. Like if this person, also drinks 3 beers per day, and we're looking at head and neck cancer and we're trying to compare smoking, and well, it's like, well, drinking that much can also increase the risk of head and neck cancer, so let's exclude these certain people. Whereas if you do it retrospectively, not every provider asks patients when they come in, do you drink every day? Not every So when you're looking back through the charts, you just don't know. Sometimes you have to exclude a bunch of people because they don't have it, or you just don't have that as an exclusion variable because not enough providers asked. Whereas when you do it prospectively, you can have your set list of questions, inclusion, exclusion criteria, and then randomize patients when they come into the clinic into one group or another.
Okay. What do you mean randomized patients?
Yeah, so say for instance, like one of the studies we did, I kind of talked about it as a pain study. And if patients got a procedure, whereas like a head and neck cancer procedure where they removed a cancer and then they put in, like they reconstructed that area, like if they removed cancer from their jaw, reconstructed their jaw, then we had two different branches of the study. Half the patients would be getting the normal pain management regimen, which is basically Tylenol and opiates. And then the other half was going to be getting like a multimodal regimen with pain blocks, like nerve blocks and some other things. And so when patients come in, you tell them about the study. You'll say like, hey, we're trying to find out if this new pain regimen's better than the current one that we normally practice. And then if they say, yeah, I'd like to participate in the study, then we had basically like an automated system where we would press it and it would randomize the patient to the normal pain regimen or the like multimodal pain regimen. And so each patient that comes in, everybody has their different demographics, their different backgrounds, the different things that they do every day. And so we're not picking people and saying, you go into this study because you might have a higher pain tolerance than this person, or you have a lower pain tolerance. We're letting the computer decide who goes into which arm of the study. And so that way it's just a little bit um, less less likely that we're selecting all these people with a high pain tolerance to go into one arm or they all have some confounding factor to go into one arm because it's just random. Like whichever patient comes in, the computer decides which arm of the study they're going into.
And even when the computer decides that, you don't know, right? Afterwards, until this like a certain duration into the study, who is on which regiment? Or do you find out immediately who's gonna take which regiment?
So it depends on if the study's blinded or not. And sometimes it's single blinded, sometimes it's double blinded, sometimes it's not blinded. And so it really just depends on how the study's constructed. Like sometimes, if you're giving a patient a nerve block, it's kind of hard to hide that from them, or it may be difficult to hide that from the providers. But there are certain studies where you just basically half the patients will get some medication, the other half will get the other, and it could be blinded, and so people don't actually know. Like the patients were blinded and the providers are blinded, so it just depends on the study type, and it just has to be specified in advance what type of study. Obviously, if things are blinded, then that increases the validity of the study because then there's less likelihood that there's going to be some sort of bias that comes up later on down the road.
That makes sense. But logistically, for say the study you were doing, it would be nearly impossible for the patient to be blinded because they're gonna know if they got some nerve blocker?
Yeah, so a nerve block. Yeah, and
Okay.
we also gave them some medications that like only half the patients were getting beforehand. So, I mean, technically, we could have given half the patients a placebo and half the patients the actual medication, which is called gabapentin. But that's not the way that it was designed at our specific institution. But I mean, it is plausible. People do it. That's just not how it was constructed when I had gotten there at, you know, where I was working.
Got it. And this alternative regimen of pain management, what I haven't really heard of it, nerve block, and you said it was a kind of a series of different tactics. Could you explain that?
Yeah. So basically, a nerve block is essentially just like a local anesthetic. So think about, have you ever used, like, if you cut your hand and you go to the emergency department and they need to stitch you up, sometimes they'll give you a local anesthetic right by
Yes.
where they'll inject into your skin. And so imagine that, but it's right next to a nerve that's going down your whole leg. So essentially, they'll numb your whole leg so that you can't feel pain below maybe your thigh or something like that. And so a nerve block, and you can do that with, nerves in the arm, you can do that with nerves in various places.
In the jaw?
And I don't know if you can do one in the jaw. It's possible. We never did it, but more commonly it was in the legs and the arms, which are the ones that they were doing. And so I think it just depends on lots of times the anesthesiologists are the ones who do it. So it probably depends on their comfortability too, and like where they feel comfortable providing the nerve block. But essentially, we can do that for patients if they got, because if you take out like a big old cancer out of someone's jaw, you need to reconstruct it. And there's lots of times not enough tissue there to do that. So lots of times they'll take like their bone from the leg or their bone from their arm and they'll put it in here. And so then they basically put a nerve block in the arm so that, because lots of times the arm is actually more painful than the jaw for these patients. And so they'll basically put a nerve block in the arm to try to decrease the amount of pain there.
Wow. So even the fact that, the cancer was in their jaw, but they need to get a bone graft from another part of their body,
Hmm.
and that extraction of the bone graft tends to be more painful than the actual jaw replacement where the cancer was? Is that what you're saying?
Yeah, there
Wow.
a lot of research has. that seems to be what a lot of research has shown. Every patient's going to be different, so not every patient's going to feel that way, but there is a lot of research that does support that what's called the donor site, which would be like the arm or the leg, is more painful than would be the recipient site, which is like wherever it is. If it's the jaw, if it's the tongue, sometimes it's other bones in the head and neck region. But yeah, lots of times that's kind of what prior research has shown and what some of our patients also said, just
Wow.
anecdotally.
That's that's interesting.
Yeah, it is, and I'm not entirely sure. There could be a good reason for it. I'm not entirely sure why that's the case, but um, yeah, it's something that was just part of like the regimen that they're doing, and they're also using some other like non-narcotic medications to try to decrease pain. So
Okay.
things like Toradol, which is like a strong ibuprofen. Just imagine like a stronger ibuprofen, and so things like that they were using to try to decrease the pain for these patients.
Okay. And I'm assuming that this study is being prompted with the attempt to see if there are alternatives to opiates in pain
Mhm.
management.
Yeah, either alternatives or at least decreasing the amount of opiates that people need and decreasing the pain. Because what we were seeing was that actually, people were getting less opiates and they actually had less pain with like these alternative regimens because if you're blocking someone's whole leg with a nerve block and they're not feeling their leg, then lots of times they're not going to need as many opiates and they're not going to have as much pain. And so that was a goal just in general. That's like a really hot topic in medicine, is trying to decrease the amount of opiates that people are getting, because obviously we're in like an opiate crisis where there's a lot of people who are addicted and dying because of overdoses and things like that.
There is an opiate crisis.
Yeah, I mean, I would say so for sure. It probably depends on what region, of the country you're in, but it's definitely increasing the amount of people that, you know, were dying from opiates
And
over the years.
how does someone generally die of opiate use?
Just overdosing. And so, you take too much and essentially it causes like cardiopulmonary arrest. And so a lot of times you'll just stop breathing. Your respiratory rate gets too low. And sometimes what happens too is people who have been taking it for a while and then they build up a tolerance to it. And so they keep taking more and more to get the same effect. And then, either one day they take something that could have been laced with something that's stronger, like fentanyl or something like that, or they just stop taking it for a while and then they take it again and they think they can start at the same dose that they stopped at, but their body has kind of lost that tolerance. And so now if they, take the high dose that they were taking before when they're doing it every day, sometimes that'll kill them.
Wow. That that is yes, and I'm assuming, that can, you know, get away from people, if it becomes a daily habit, taking a pill or a couple of pills, and eventually, after a few years, it's just, n- a normal habit. So you've said pulmonary, cardiopulmonary, and I was gonna ask earlier,
Hmm.
is pulmonary and respiratory or cardiovascular, are they synonyms? Are they interchangeable, or they distinct aspects of our anatomy?
I mean, it's connected for sure. I mean, different doctors will specialize. Like there's cardiologists who focus on the heart, and there's pulmonologists who focus on the lungs. But nothing in our bodies really in isolation. It does affect the other thing, and so if you're having difficulty breathing, or you're having an asthma attack or something like that, Or if you have like COPD, which is basically like people who smoke a lot, they'll get like this chronic obstructive pulmonary disease. Lots of times that can affect your heart and how it functions and its ability to pump blood through your system and how hard it needs to work. And so everything is related because oxygen comes through your lungs and then it goes into your bloodstream and it's pumped around by your heart to your tissues, and then it goes back to your lungs and it's breathed out, and then new oxygen comes in back pumped through your heart again. And so everything's kind of interrelated, but I mean, people do specialize in certain things, like cardiology. If someone's having a heart attack, they're they're going to be seen by the cardiologist. I mean, they're going to come into the emergency department, but then they're going to go to the cath lab, which is where the cardiologist is going to try to like reperfuse their blood vessels. And so, a pulmonologist isn't going to really do much for them. But at the same time, you know, someone's having a heart attack, you are also trying to ventilate them at the same time. And so everything's kind of related, but it's like a different organ system. But lots of times cardiopulm is something that people will say together, like is a common one that people be like cardiopulm, or sometimes they'll say like cardiorenal, which would be heart and kidneys, because those are in two completely different regions but of the body, but they still affect each other. And if your heart's not pumping blood to your kidneys, then your kidneys aren't going to perfuse well, and you're not going to be making urine. And so there's a lot of like interplay between our organs that goes on.
What does perfuse mean?
Perfuse. So when you're talking about perfusion, it means like getting blood to an organ. And so if you say it's not perfusing well, that means you're not getting a lot of blood to that specific organ.
Okay. S- So any organ can perfuse.
Uh, yeah.
Is there any organ that doesn't have blood flowing through it?
There. I'm trying to think. I mean, most organs require blood. There's certain that don't require as much perfusion as others, and you're
Like
kind of
the
putting me on
stomach?
on the spot. No, the
No,
stomach.
don't worry. You don't have to Google it. I was just because it would make sense that blood flows through all of them.
Hmm. Yeah, no, I mean, there's certain things that like your nails or your bones or things like that. They don't require like the same amount of perfusion that your kidneys do. And so there's definitely different levels to perfusion. Like your hair follicles, the top of my hair isn't necessarily having blood going up and down and up and down the whole time. You know what I mean?
Yeah, that's a long distance it would have to flow.
You used to have hair like this too.
Me? Oh, yeah, I did. I did. That was a few years ago.
Yeah, man,
But
I got a picture of it.
yes, you do. Yours is much straighter than I mean, yours is pretty curly, but it's still pretty straight to where it goes like
Yeah,
downwards.
mine's wavy for sure.
Yes, it is wavy. Is that the longest you've had your hair e
Yes, it is. Yeah.
ever or
Yeah, for sure. I have had it. Let me see. How long is this? This is
it's
I
pretty
maybe
long?
have had it this long with a comb over, possibly, but it was only long on the top. It wasn't long on the sides or the back. And so this time I kind of grew it all out. And then when I was in middle school, I used to like it where like you can poof out the sides. I guess I don't know, that was the look, or I thought that was the look. And
I
so
don't
back
know what
then,
that is. Poof out the sides.
it's almost like you had wings coming out
Of
like
the
this.
back?
Yeah.
Wow, that's like the opposite of what college and afterwards was. Now everyone shaves the sides.
Yeah, no, that's definitely been a look, and that's what I've probably done the last I don't know, 10 years, is have it tapered on the sides and with a comb over, and sometimes I'll just buzz all my hair when I feel like it.
Yes.
But this time I just kind of felt like doing something new.
Nice. When was the last time you got a haircut?
Uh, I shaved it all off in February, and then I cut the sides a few times, maybe up until like late March. I was just buzzing my own hair at that point, and then maybe like late March was the last time I actually cut it. And so
Okay.
my top is a little bit longer than my sides by maybe like an inch or so, inch and a
How
half.
how do you cut the sides?
Just with like the buzzer, basically.
And do you cut like do you shave pretty much the entire way around, like the back end too?
Yeah, man, I was actually getting pretty good at it too. A lot of it's just feeling. You can kind of feel where like your bone ridges are and stuff. And a lot of it's trial and error too. But if you kind of just keep adjusting it in like tiny increments and go over the same region, like lots of times you can blend it pretty well. And so I cut a few people's hair when I was in med school. There was somebody who used to used to cut everybody's hair. He was a roommate, and he actually gave really good haircuts. I don't cut it with scissors. I've never cut anyone's hair with scissors, but with like a with the
Razor.
buzzer thing, I can definitely, cut at least the sides until my hair gets so long that it needs to be blended like properly, and I can't do that. But if it's like, only 2 inches long or something, that's not too difficult.
Okay. Did your roommate charge for haircuts?
It wasn't my roommate. He used to only charge like $10 or something crazy. It was,
Wow.
and he did a good job too. And then at some point, he's like, "Man, you don't have to pay me anymore. Like we're friends." I'm like, dude, you're so nice. It was funny because I would wait. He ended up moving to New York maybe when I was a second year in med school, and I would sometimes wait 3 months for him to come back to cut my hair because
Wow.
not only was it like, I mean, he was doing it for cheaper at the time than like anyone else in DC because DC charges like 30 bucks. But he also did a better job, dude. I would go to these people and they would just mess up my hair like time and time again. And like this guy who just only practices on his friends was the thing is, I think, and I think this is may not be the case with everybody, but I've noticed with guy barbers, they don't listen. Like you tell them what you want and they just do what they think looks best. And I've
Really?
actually, at least for me in my experience, I've gone to female barbers and I feel like they listen, they do what you ask them to do, and then they'll give you recommendations and you're like, "Oh yeah, that sounds good." And then they'll do it. And like honestly, most of the female barbers I had were a lot better than the male ones I had, except for him. He was really good because he listened. Where some of the other
Okay.
people in DC just didn't listen, and so I just stopped going. I would just cut my own hair, and um, then I would like go to a female barber if I could find one, honestly, because I felt like they did a better job.
Wow. The best barbers that have cut my hair have been female, the most notable ones.
Really?
I don't know if that's anything to do with me not, you know, searching out for male barbers, but yes. It would be tough to ask for a certain haircut and then the barber not listen to it and do something that he thinks is better. Uh,
Dude, yeah. No, I feel like and maybe I am a little picky or something, but I would whenever something bad would happen at the last barber, the next barber, I'm like, and please make sure that you don't do this. And then I wouldn't tell them about like a super simple thing, like just cutting the sideburns, like to make sure it's like even. And I get home and then I realize they never did that. I'm like, what barber doesn't like cut the sideburns? And I wasn't paying attention because I'm like, the last time they left the back of my hair like an inch longer than the front of my hair. So like that's what I was focused on. And so I feel like the whenever I've been to female barbers, I just felt like they did a better job. And then my friend who would come down to cut my hair, like that guy, he just listened very well. And so I think he just did a good job.
wow. So you've resorted to not no haircuts at all.
Basically, man. Basically.
Hey,
I
that's
mean,
not bad.
yeah, I've always wanted to grow it out and just with interviews and random things in life, I I wanted it to look professional at those points. And like when I'm growing out my hair, like there's a middle stage where it's just, I'm sure you went through it,
Yes.
or it's tough, man. It's
Yes, it
tough.
is. It
It's
doesn't
probably,
look great.
no, it's tough for your significant other to get through the day.
But I'm sure she's happy now. Like, you have
Yeah,
I think the hair looks nice now.
thanks, man. I appreciate it. Yeah, she's just nice in general. She'll probably even compliment it even when it's at the middle stage that looks awful.
Wow.
So, I mean, she'll compliment with like, I have a mustache, and everyone else is like, that looks disgusting. She'll be like, you look so good.
Nice, nice. That's a
Yeah, it's
keeper for sure.
a good person will
Yes,
just compliment you regardless.
yes. On the goatee too? Or no? No compliments on the goatee.
Um, no, she likes the facial hair. The one thing is like I have some hair here just because I can't grow it. That she's like,
Okay.
"Just line it up a little bit," which I don't really have that much hair. Like this is the most facial hair that I've ever been able to grow.
Okay.
I mean, I shaved it maybe like a month ago, and that was the most I had ever had. But like now, I'm able to start growing facial hair to an extent, but it's still not thick and full like yours. And so like me lining mine up, it's like kind of hard because what am I lining it up with? More
Yes.
patchiness. And so
Yes.
like I get what she's saying and maybe it could work, but like I don't know if I could do it because mine in general is like a little bit patchier as it gets up towards the sides and stuff.
Yes. But it will grow in. It'll fill out, I think, within the next 5 years.
I think so. I think it's trending in the right direction at this point in time. And so
Nice.
it's more than I ever used to get in undergrad by a long shot.
What about in med school?
Even med school, like I feel like over the last year and a half, 2 years, it started growing in a little bit more. And it's obviously not a lot. I know there's like 18-year-olds. You
Four
probably have.
14-year-olds, dude, 14. I've
Yeah.
yeah, I've been able to grow a beard for a long time.
Dude, yeah, I bet. I'm not surprised. But
Wow.
yeah, part of it also too with the long hair, it's just like, to an extent, if you have long hair and a clean shaven face, sometimes you look a little bit like a female,
Yeah.
or at least some people do. And so for me, I'm just like, well, this is clearly a male face.
Yes.
And so I don't know. I feel like for me, it goes well with it, but probably at some point I'll shave it all. I shaved off everything but the mustache not too long ago, and that looked pretty bad.
Wow. You mean just everything on your chin and your
Yeah.
jawline?
Yeah. Probably like a month and a half ago, I had only the mustache.
Have you tried just the, shaving off the jawline and keeping the chin and the mustache?
I used to. I haven't in a while. I'm not really sure. I know it's a look. I know it's a look, but I
Because
kind
you
of,
because it's pretty full here,
yeah,
and so it would be like you could line that up and it would look
yeah,
not patchy.
yeah, that's true. I could try it for sure. I would prefer if it grew in full, but what can you do with genetics?
Yes, you can't do much until CRISPR, and then you just give your baby Thaddeus Odom's beard at 3 years old.
Yeah, man. Back in the old days, it was self-selection. Now you can do what you want with the DNA and just make it good, I guess. Hopefully
Hopefully.
not.
Do people in medicine ever talk about that, or is that a thing that of discussion, like genetic editing?
I'm sure it is. I feel like it was talked about more when I was in college than
Yes.
at least medical school, and I'm not entirely sure if that's just because, I was a biochem cell bio major and that was the focus on sort of like DNA and genes and things like that, or if it's just medicine doesn't focus on that. I'm sure if I was in genetics, like that is a specialty of medicine you can go into, I would imagine they they probably talk about that a lot more, but I can't even think of the last time we've discussed CRISPR-Cas9, at least amongst like my colleagues or in my classes.
Because you're doing very practical work, and CRISPR-Cas9 right now is lab work, theoretical, like still in the beginning stages where you're helping patients.
Yeah, and I mean it's also just, ethical issues galore with that.
Yes,
And whether or not it's like ethically permissible to be changing human DNA, and what's the extent at which we can do that.
absolutely. It's actually, I've spoken about it a couple times. I think one of the big hesitations is like we have these children that are genetically enhanced, maybe their intelligence or their athletic ability or even their immune systems, and we're stuck here not genetically enhanced. And it's just like you have these two different types of people. I think I'm kind of scared of that, where it's like, wow, you know, like, so who is like, what's going to happen there? How's the imbalance going to work between the people that can somehow gain access to this and the people that can't? I mean, and is it if it that's if it's positive, it could be negative. I've heard that CRISPR-Cas9, like you edit one gene, one strand of the DNA, and actually there are ripple effects that affect multiple other parts of the sequence as well.
Yeah, I mean, I don't doubt it for sure. There's so many different proteins and factors that play a role in gene expression. And I haven't studied this for a long time, and I don't really know where the research is at. But I can imagine that it's hard to sometimes just get one gene in isolation and one trait in isolation. To get Thaddeus's beard on
The 3-year-old.
a 3-year-old. But who knows? I haven't really looked at it. You said you've discussed this a few times. You just bring it up every
Well, it's an interesting one for sure. It's yeah, I have. I mean, I don't know if I brought it up on the podcast, but I've talked about it with people.
Oh, got it. Which podcast number is this? Do you know?
This is gonna end up being 49.
Wow, man, I'm glad I made your top 49
Yes, top
people
4.
to interview. That's
Yes, you did. I
truly an
mean,
honor.
yes, you're higher than 49. It was just I maybe asked you a year ago.
That's true. But no, you
So
did. You did. That's fair. That's
so
fair.
it's even higher than 49. Oh
Yeah.
man,
Well, we finally made it happen.
we finally
And
made it happen.
the crazy thing is this podcast was supposed to be about dogs, and we haven't even discussed.
Oh man. Yes, I mean,
We haven't even brought them up once. I love
no. No. They get a lot of attention. I know Argon gets no shortage of love.
Oh, absolutely not. It's different though now because this is the first time I've ever lived alone, and so I don't have any roommates. Which he definitely loves having a roommate, so I do feel bad about that. A lot of the times I've actually kind of selected my housing. I mean, most of the time I've honestly all my housing choices have been thinking of him, and where is he allowed to live, particularly, not every place allows dogs, particularly in DC. And then you know are there people that can also be there to just excite him because he just enjoys being around people. And also, rent prices in DC are so astronomical that sometimes it just makes sense to have roommates.
Yes. But you
But
live by yourself now?
yeah, this is the first time I've ever actually lived by myself.
Wow, how has it been?
It's good, man. I mean, it's nice to just come home and I have Argon who's excited to see me, and I usually take him out. I try to take him out every day if I can for like a run or just fetch. just so that he still gets his exercise because he's a super energetic dog. But it's nice that, I started like decorating my own place. I've never done that before. I never used to put anything on my walls until I lived with my girlfriend for a year, and she was all about decorations. And so like I'm starting to like put pictures up, and like my guitar you can see is hanging on the
Yes.
wall behind me. And so we've got even a backyard that like back there's a backyard area where I built him like a little porch potty, which he doesn't use.
Nice.
And I've got like a pull-up bar and dip bar and stuff out there and a little table. So it's nice. I like my area. It's just it is expensive for sure to live on your own rather than have a roommate.
Yes. I think it is much more expensive, but I think there's a lot like you don't have to rely on anyone for your living anymore.
Hmm.
I know when I was living with roommates, there were two situations back to back years where it was one roommate needed to leave and it just it's really tough to get up and move and switch homes every single year.
Oh, absolutely, man. I didn't live in the same place until for more than 1 year until like my third year of med school. I was finally in the same house.
That you'd
Like,
been in your second year?
yeah, that had been in my second year. So like 4 years of undergrad, I was always switching, then one master's year, then a year of med school, and then finally my second, third, and fourth year of med school, I stayed in the same house. But like that's six or 7 years that every year I'm switching. And sometimes in the summer I would be switching twice. It's like a
Wow.
summer home and then a home because I was an RA when I was at UCSD, and so like summer was always different than the actual year, and so it is nice to have like a stable place right now. And I don't know, if I'll stay in this next year or not. It kind of depends um, on like whether or not my girlfriend moves back out to DC. But if she doesn't, then there's a good chance I might just stay in this place because it's just such a pain to move.
She couldn't move in there? Is
Um,
it too small?
she probably could. It is a little bit tight though. I would definitely probably have to get rid of stuff, and then all my decorations would have to come down so she could put up her own stuff, which is fine. I mean, she has good taste, so at this point, like I have, which is nice, I finally like have money to kind of do some things. I mean, it's not a
Yes.
lot because I'm spending most on rent, but still.
Still, having some is better than having none.
Yeah, exactly. And so I like the area I'm living in. Um, it's like a good part of town. There's a lot to do in this kind of area, and it's not right next to where I work, which is where I used to live by where I worked, and it was convenient for medical school. But it's kind of nice to be a little bit farther out.
Really? What's the reason you say that?
I just feel like mostly because the part of town where I worked, it's like everything closes at 9 p.m. And so if you want food, if you want to do anything fun, you're going to a different part of town. You're going to have to Uber there. You're going to have to get there somehow. Whereas now, if I want to, which I don't really because it's COVID and also just residents lots of times have different schedules. And so I don't go out nearly as much. But if I want to go out, like they had a Halloween party, for instance, a week ago, and I just
Who's
walked out of
they?
my door, like the residents. So they did it for
Nice.
internal medicine residents. I just walked out my door, walked down the street 3 minutes, and I was at like this club that they had reserved for internal medicine residents only.
That's awesome.
And so then I went during the middle of the like party or whatever. I went back home, put my laundry in the dryer, and then went back
That's awesome.
went back to dance.
That is and do you have a car?
I do, yeah.
Or do you need your car to drive to work?
No, so I actually scooter to work. I have like an electric scooter that I use, and it's
Wow.
a 10-minute 10-minute ride each way.
Is it like a seated scooter?
No, it's just stand up.
Okay. And it's yours? It's not like a bird?
No, it's mine. I bought it um,
When did you
purely
buy
for
it?
transportation. What?
When did you buy it?
I actually bought it about a year and a half ago at the end of med school, um, because I figured I would need it at some point. And like honestly, for work, sometimes it not here particularly, but when I did my research position, it was the parking lot was not even close to where I was going to be working. And so I would have had to drive to a parking lot, park, and then walk like, 15 minutes or shuttle to work. Whereas if I just scootered directly there, I got there in like 8, 10 minutes. And so for me, it just made more sense. And that's what I do most of the time now. I just scooter to work and then scooter back. And then if it's like poor weather or something, then I'll drive.
Where do you park your scooter? How do you park it?
Park it in the trunk of my car. So I have parking at the hospital, like in a parking structure. I usually leave my car at the hospital, and
Wow.
then, and I'll just like park my scooter because the problem is here, like it's all outdoor parking, and I have a parking permit for the city, but my car got broken into like first 5, 10 days I was here in DC.
Dang.
After like I had come back here from Kansas, and I'm like, I don't really want to leave my car out for extended periods if I don't need to. So I usually keep it at the hospital because it's like a locked parking garage, and so that way I don't have to pay for window repairs or whatever people steal from my car.
Yes, that's terrible. Ha have you seen in San Francisco, people will put like, my car and my trunk are empty. Don't break my window. And they'll put a sign out on their car. They'll keep it like they'll just say, my car and my trunk are empty. There's nothing to steal. Don't break my window.
No, I haven't seen that. I wonder if it works.
I think it might work because if you keep your at least car empty and you put that out there, I mean, at least you're not clueless. And I think that's if a homeless
Mm,
person, at least if like, I don't know, who knows what they're thinking, but if I was a person looking to steal from a car and that was
yeah,
there, the easiest targets are the one who don't even know that I'm going to try and steal anything. So if this person at least understands that there are people stealing things from a car, then why even take the chance to break it if they, it's that even if they're lying, it's way
mhm.
more likely that there's nothing in the trunk.
Yeah, but the thing is, you are overthinking what I think more than some of the people who usually probably break
I
into
I
cars.
agree.
Because the people that broke into my car or the person stole like 40 cents from my dashboard and coins and my sleeping bag. And so
Sleeping was your sleeping bag in the car?
it was in the trunk of the car.
That's
And
valuable for a homeless person.
it is. I mean, they didn't know that, but they stole like 40 cents from my dashboard, which is not very much money at all.
No, but the sleeping bag's big value. I mean, it could what DC is a cold place, and if they're sleeping on the street, I mean, sleeping bag makes that experience way better.
No, I don't disagree, but at the same time, part of me thinks that if you're willing to take 40 cents from somebody's dashboard, then you're probably not overthinking a lot of what you're doing.
No,
You're
you're
probably
not.
you're
No.
probably just breaking and looking. Because I mean, I had other stuff. I had a camping tent in the trunk that's more valuable than a sleeping bag. If you're really sleeping on the streets, it was a six-person tent they could have had, and
That's a pretty big tent.
yeah.
That might go over the sidewalk.
Well, yeah. But I mean, I don't, obviously I don't know who broke into my car. It could have been anybody, but the fact that
That's
they took
true.
40 cents in a sleeping bag is just I didn't actually know they took the sleeping bag for probably a month and a half till I went on a camping trip and I'm like, "Where is my sleeping bag?"
Really? Oh, wow.
I just thought they took 40 cents for probably like the first month and a half.
And
Uh,
then while you were on the camping trip, you realized?
I fortunately had a second one. It was as I was packing for the camping trip. I'm like, "Where's my normal sleeping bag?" I had like my girlfriend's sleeping bag, so I'm like, "I guess I'll use this," but I couldn't find mine anywhere, and so
Oh,
that's when I figured it out. That I'm like, "Oh, it's probably in my trunk."
got it. Okay. Wow. All right. Well, keeping the car in the hospital parking structure then.
Yeah, exactly. And so, I mean, my scooter folds. I could probably take it in the hospital. I just don't, just because I would imagine that they wouldn't let me wheel it in. If I folded it up, they'd probably let me carry it in, but it's kind of heavy. So I just park it in the trunk and like there's a lot less risk of, anybody taking it.
Nice. Well, that's good. Scotty, I won't keep you here too long. I know you said you gotta go. Are there any last words you'd like to tell the audience?
Uh, I don't have anything particular to say, but I appreciate the opportunity to talk with you on the podcast. I know you've been grinding on this and grinding with your workouts, and I'd actually love to talk before I go about your workouts, some of the like swordsmanship you've been doing, and
Oh, you want to talk
yeah, let's
the
talk about
mace
that. Let's talk about that before I leave.
the mace work?
Yeah, that thing you go. Let's talk about that one, dude. What is
Dude,
that workout?
that's a mace. That's an old Iranian workout where they I don't know what it works out, but it's all mace work.
Do you feel like it strengthens your mace work part of the body?
Yeah, I definitely think it does. I don't know what it actually strengthens though. It's like I don't know what it strengthens. I think it's more about using it as leverage or something.
So I guess what's the purpose of doing that opposed to, a more conventional sort of workout?
I would guess that it's more has I think the shoulders,
Mm,
it gets a lot of dynamic movement in the shoulders
okay.
and versus a conventional workout where you're isolating a lift, this is a lot more integrated across muscles, especially in the joint of the shoulder, a little bit of the abdominals, not much.
Mhm.
So I would say it's mostly to do with anything from the pec up. I've injured myself pretty bad using it. Like I
I don't doubt it, man.
yeah, I tried to like flip it, but then like I didn't use the leverage correctly, so like I strained
Oh, jeez.
my back pretty badly for like 2 or 3 days. It was hurting.
Oh, no. Yeah, man, that sucks. Yeah, I feel like I just don't go too high up in weights anymore because it's just not worth straining a muscle over, at least
No.
for me. I'm
No,
not
it's not.
not doing heavy lifting. I will say, like, I used to do a little bit of boxing, and it was a really good workout, but it always threw me off for, the rest of my workout routine because I'm like, I did a little bit of back, a little bit of like, I feel like I've got a little bit of muscles all over, and then now I don't know how to do a conventional workout to supplement what I did boxing. And so for me, it's a little bit easier to just like focus on a specific muscle each day. Um,
Yes.
but I don't know if that's the way you feel about it.
No, I don't do that, but I understand people who do. Like, so how do you work out now?
So I usually run every other day, and so that's kind of, my cardio and legs. And sometimes with like leg day, depending on how much, because Argon can't run quite as much as he used to in terms of like long distance. Now that he's a little bit older. And so when I get home, sometimes I'll do like legs that day. But in between days where I'm running, I'll usually do upper body. And so I'll focus on either, I usually group together shoulders, triceps, and chest, and then biceps, back, and traps. And then I'll just do abs usually at the end of whatever workout. And for me, that's just what's usually been easiest in terms of like time and focusing on specific exercise routines. And I'll usually just switch that off. And I mean, I try to work out every day if I can. Some days it just gets busy and I can't.
Yes. That's yes. Whatever. I mean, you've always been in very good shape. So you do long distance? I know you sprinted in high school, or sorry, in college.
Yeah, so I mean, I still, if I can, I'll do sprints. It's just, it depends where I'm living and if there's like a big enough grassy area for us to do sprints without a bunch of other people walking through or dogs running through. And so where I live now, I can sometimes get that because there's a park nearby, but sometimes it's a little busy. Back when I lived near like the, the
Hospital?
Washington, yeah, by the hospital, I was a lot closer to the Lincoln Memorial. And actually, there's a lot of grassy areas down there that nobody even touches except for like occasionally soccer. And so I'd go down there, I'd do a lot of sprints. But like now, it's sometimes just easier to do some long distance and then come back. So it just depends on, what I'm feeling like that day. I do prefer sprints, but I just don't have as good of a park to run at that I used to have.
You used to do sprints near the Lincoln Memorial?
Yeah, dude, I would go down there almost every single day with Argon and either play fetch with him or do sprints like, I don't know, maybe 150, 200 feet from the Lincoln Memorial. It was really beautiful.
Wow, that's an iconic place to work out.
It was, yeah, and there's the Potomac River cuts like right around there too. And so sometimes if I did do long distance, I would go like down to where the Lincoln is. You can sometimes run across where like the water is. And there's a bunch of other monuments that you just keep hitting along the National Mall. And sometimes if you go past it, you could run along the Potomac River as well. And so it just depends like what I felt like doing that day. But most of the times I did do sprints. Sometimes I'll do long distance. But it's not that long distance, dude. I can't do like like some people do like 6 to 13 miles. I can't do that. My long distance is like 3 miles.
3
But
miles is solid.
yeah, 3 miles at like a little bit of a faster pace with Argon stopping every now and then to like mark his territory.
Yes. Without any regard to whether you want to go or not,
Whether I want to go on the tree too.
or whether you want to continue running or not.
Oh yeah, dude. Sometimes I don't care as much. If I'm tired, I'm like, all right, we'll stop. But like,
Yes.
there's some times where he's just tired. I'm like, dude, we just stop. Come on, man. Like, I know
Yes.
you're 7 and dog years, but you gotta like. And but if he sees another dog in front of him, then sometimes he'll sprint, and I'm like, dude, you're usually tired at this point in the run.
I
Yeah.
know.
Do
Then
you
that
run ever with Asha?
Asha, yeah,
Asha?
I do. She likes running. I know sometimes when I go on trips I give her to my dad and my dad jogs with her too.
Oh, nice.
She actually I don't know why, but she's way more snarky with me than
Mm,
with my parents. Like my parents are like, "Oh yeah, she's an angel. She doesn't do anything." And my dad says when I go running, she just stands by me. I'm just like, "Wow, that's not the case with me." Like she's always like challenging me, always trying to push the edge
like how?
like anything that she wants to do that she knows I won't like, she just tries and I don't know. She's not bad. She's a good dog. She's a very good dog,
Mhm.
but she definitely likes to have fun in whatever way she deems.
Huh. What do you mean, like, snarky, though? Like, is she being protective over you? Is she, like, disobeying you? Like,
No, she's not being protective. She's more like say we're going out for a walk and I'm trying to say, like, trying to get her to keep on going, she'll just stop because she wants to smell something there. Or
Oh,
like
okay.
it's like it's nothing terrible, but it's more like just these small things that she doesn't really mean to be mean or anything. She just kind of wants to do her own thing. And I have my way that I want to go about the day. And then, like with my parents, she just doesn't care and she just gives in immediately. But with me, she definitely puts more of a let's do let's go my way instead,
Huh.
if that makes sense.
Did you do any dog training with her at all?
Not any true dog training. Did you do it with Argon?
Yeah, I've had a few different trainers for him.
Really?
Um, and I mean, overall, he's a very smart, intelligent dog, and he's well behaved for most things. But there's certain things where he's very hard headed, and I've even had, I think it's because he's half husky. Um,
He's half husky?
yeah, he's German Shepherd Husky mix.
Wow, I didn't know that.
Really?
Shepsky?
I guess so. Shupsky.
I think that they call them Shepskis
I've never even heard that, but yeah, I guess he's a Shupsky.
because Asha was in a doggy daycare with an owner of a Shepherd Husky mix, and she called her dog a Shepsky. So that's where I got it from.
Oh, okay. I've never heard that, but he definitely is like can be hard headed. It's interesting because he listens to me better than he listens to anybody. And so for me, if I tell him to do something, like if somebody's over and he has the ball and he wants to play with them, he's gonna try to do tug of war with them, and they're gonna tell him to drop, and he's not gonna drop unless he like really knows them or if they stop playing with him altogether. Whereas with me, he just knows that I've been with him so long. I tell him to drop, he's gonna drop it, or things like that. But he's also really protective over me. And so even, when my family takes care of him or things like that, they're like, he's so much better behaved when you're not there. Like
Wow.
he's so much better around like us. Like he's more affectionate. He does all these things when you're not around. And
That's,
like
I think, exactly my dog.
he's
Wow.
because he's like, I mean, sometimes, when people want to pet him and stuff, he's just like, you can tell he's mad. He doesn't want to be pet by them. But if I'm gone, if I'm not there, then he's coming up to them to be pet. And it's a weird thing. Even with the vet, sometimes when I take him to the vet, like he's psychotic there. He's like he looks like a crazy dog. And then sometimes so they'll take him off and then they'll give him the shots. And they'll be like, oh, he was so easy, like after we took him away. And I think he's just whenever he's attached to me, he's just very protective. Which is something that one of the things that just with a trainer that I've tried to, work with as well, just to decrease that. It's difficult because you do need other people. Like some of the tendencies he has, you need other people to work with him to make him do things so that he respects them. And the more I work with him, the more he'll respect me and not necessarily respect other people. And so it's he's gotten really good at a lot of things, but there's certain things that, I mean, even now he can still, if I had all the money in the world, I would definitely, get a better trainer than maybe what I've had before to try to get him like top notch dog.
It's a lot of time on your part, a lot of effort and a lot of
Mhm.
energy. Not even
Yeah.
just money. It's like you need to that's consistent, cueing and consistent reminding him of what you should and shouldn't do and getting him into situations where he actually can
Hmm.
make that decision pretty often instead of it being like once in a blue moon and then you're not really able to train for that situation and then it happens and he doesn't
Hmm.
react how you want him to and then it's kind of upsetting. It takes a
No,
lot of effort to get that training in.
absolutely. You need to put them in situations where they're going to be provoked or do something that you don't want them to do so you can correct them, before they do it. And that was the thing, like when I lived in Kansas, when I was training them there for a while, when I go on walks, like people don't walk in Kansas, they drive. And so I would walk and sometimes not come across anybody for a 30-minute walk. Whereas here in DC, you know, there's a lot more opportunities for people walking by or dogs walking by to try to correct him if he's, you know, if he's getting riled up or if he's starting to growl at a dog or something. And so it's, yeah, I mean, it's a lot of time. It's also just, you know, you've got to be able to put them in the situation where you can correct them. It can't just be once every blue moon, like you mentioned.
No. Wow. So we'll see where Asha goes and where Argon goes. Probably, I mean, we have to put a lot of energy in to change it.
Yeah,
Yours already 7 years old. Mine's still one, and so she's got a few more lessons to learn.
yeah, for sure, man.
Well, Scottie, do you have any last words you'd like to tell everyone?
No, I don't. Thanks for having me on the podcast, though, Karush.
You're welcome. My guest today has been Dr. Scott Fassas. Thanks for coming on the podcast, Scott.
Pleasure to be here.